My name is Judy Yee, and I am Professor and Vice Chair of Radiology at UCSF, Chief of Radiology at the San Francisco VA. And I'll be spending the next 45 minutes or so discussing the pancreas. I'll start off by briefly going over pancreatitis, and Dr. Sun has already gone through a lot of acute pancreatitis with you, so I'm just going to touch on it, but really to bring home the points and to emphasize the correct terminology that you should be using based on the revised Atlanta classification. My focus really will be reviewing chronic pancreatitis and the two subtypes that you may have heard of, groove pancreatitis and autoimmune pancreatitis, and then we'll talk about the congenital anomalies of the pancreas, and my main focus will be on the solid and cystic tumors of the pancreas. So as you all know, most cases of acute pancreatitis are due to alcohol and cholelithiasis. You can see the list of less common etiologies. The good news is that by far up to 85% of cases are actually mild, and it's only in about 15% of cases that you will have complications, in particular necrosis. Now, the original Atlanta classification was developed back in 1992, so about 25 years ago. And in 2008, a work group was assembled to revise the classification based on the need for more uniform terminology in describing the fluid collections. And I hope that this slide will make it easier for you to understand and to remember the terminology. I put the 4 weeks sort of in that star up on the upper right, just to remind you that 4 weeks really is sort of the time interval that divides the terminology that you're going to use, all right? So the first thing you have to know is that there are two morphologic types of acute pancreatitis. The first is the mild form, and this is the interstitial edematous pancreatitis, okay? This is the type that typically does not become infected. The second type is necrotizing pancreatitis. Now, when you look at the terminology for fluid collections, again, it's based on this sort of 4-week dividing line. If it's within 4 weeks of when the patient develops symptoms, for the interstitial edematous type of pancreatitis, and this will be by far the most common type that you're going to be seeing, then you're going to call the fluid collection APFC, or acute peripancreatic fluid collection. If it's greater than 4 weeks after the patient has developed symptoms, then it's a pseudocyst. And this makes total sense because we all know it takes at least 4 weeks to develop pseudocysts. All right. Now, for the second type of morphology that you need to know about, the necrotizing pancreatitis, if it's within 4 weeks of the onset of symptoms, then the terminology is PNPFC, the post-necrotic pancreatic fluid collection. All right? If it's greater than 4 weeks, then you're going to call it the walled-off pancreatic necrosis. And I've seen also walled-off necrosis without the P in it, so either one. All right, so hopefully that makes sense and makes it easier for you to remember the different terminology. Okay, this is drawn from a paper that I thought did a nice job in including demonstrations of the various fluid collections. And to bring home the point again, that for the interstitial edematous pancreatitis morphology, which is what you're going to see most of, you're going to talk about the APFC, right? The acute peripancreatic fluid collection if it's early on and it's less than 4 weeks since the onset of symptoms. If it's after that, then we're talking about developing a fibrous wall around that collection, and that's going to be a pseudocyst. If it's the necrotizing pancreatitis morphology and less than 4 weeks, then it's the post-necrotic pancreatic fluid collection, all right, the PNPFC. And if it's greater than 4 weeks, and that's where you can add the modifier if you see gas, you think it might be infected, of whether it might be infected, and that's the walled-off pancreatic necrosis or walled-off necrosis, all right? So I refer you to this paper. Now, what they don't want you to use, okay, and how many have used this, is the terminology abscess or phlegmon, okay? They want to do away with these two terms, so you're not supposed to use them anymore. All right, so you're all familiar with pseudocysts. As I mentioned, takes at least 4 weeks to develop. There should be no enhancing internal contents. Calcifications, when they occur in the wall, are uncommon, and they can extend anywhere. Remember, this is full of enzyme-rich fluid that can dissect through fascial planes, and so they can go up into the mediastinum, and really, we've seen pseudocysts everywhere, so just keep that in your differential. Now, what about this? Where you have an enhancing lesion sort of bathed in this inflammatory fluid. It is enhancing to the same degree as the aorta. And these are two different patients, one with a large one. And in fact, here you can see splenic artery sort of leading into this. So no mystery, these are splenic artery pseudoaneurysms, okay? And splenic artery is the most common location for pseudoaneurysms in the setting of pancreatitis, with the gastroduodenal artery being the second most common. Okay, chronic pancreatitis, this is where you have permanent structural and functional damage of the gland. By far the most common cause will be alcohol, and you can see the other etiologies. Now, with the chronic inflammation of the gland, this does predispose you to a small chance, although it is a real chance, of developing pancreatic adenocarcinoma. And as I mentioned, we'll talk about the subtypes in a bit. Now, what are the imaging findings of chronic pancreatitis? You're all familiar with this. So you can have parenchymal calcifications, actual intraductal stones. The gland may be enlarged, or it may be atrophic. The double duct sign, you're all familiar with, as a finding for adenocarcinoma when it involves the head of the pancreas, but when chronic pancreatitis involves the head, it's very fibrotic and can also cause the double duct sign. The pseudocyst pseudoaneurysms, and obviously portal vein thrombosis and SMV thrombosis. All right, groove pancreatitis is something that I think more and more of us are diagnosing, because we're finally sort of understanding that it's actually an entity. This is a subtype of chronic pancreatitis. The appearance is of a hypodense mass-like lesion, often with ill-defined borders, sitting in this pancreaticoduodenal groove. Occasionally, you may see delayed enhancement if you performed delayed phase imaging. With chronic irritation of the medial wall of the second duodenum, and you can see where in the groove it really touches on this medial wall, you can develop cystic dystrophy, and you'll actually see small cysts sitting right in that characteristic area. Now, the big differential here is obviously adenocarcinoma, because again, the head is the most common location for adenocarcinoma, and so often these have been biopsied in the past, and all that you will find is fibrosis. Now, this is the pancreaticoduodenal groove. Again, notice that it's very ill-defined. It's demarcated by the pancreatic head medially, the second duodenum laterally, and then by the common bile duct as it sweeps posteriorly. Here's another case of groove pancreatitis, and it's just this really sort of vague, hazy, ill-defined soft tissue sitting in that correct area. This is just an example of cystic dystrophy of that medial duodenal wall. And again, it's because of the adjacent chronic irritation and inflammation, and very nicely demonstrated on this T2-weighted MR. All right, autoimmune pancreatitis is the other subtype of chronic pancreatitis to know about. I think in contrast to other types of acute and chronic pancreatitis, there's usually no history of alcohol intake. Remember that this is part of a systemic autoimmune disease. And you have to think about this because the clinicians will then order IgG and IgG4, and these levels are typically markedly elevated. Now, the typical appearance is usually involvement of the entire gland, which is swollen and enlarged with a rim of low density. Again, important to recognize, here's a case on MR, and you can see enhancement here and a rim of low density. But these patients are treated with steroids, and that's particularly effective. So this graphic just shows you, again, diffuse type is most common. You can develop these focal areas of hypodensity that can involve the head, or you can have the multifocal type, and this is the least common type. Here's a case just to show you there's mild enlargement of the gland maybe, and then this rim of low density. Well, after 8 weeks of steroid therapy, you can see there's complete resolution of that rim, and the gland has significantly decreased in size. All right, moving on to the two congenital anomalies to know about. The first is pancreas divisum, and this is where you have failure fusion of the dorsal and ventral pancreatic buds. You can see low incidence, and this is a cause of recurrent pancreatitis. Now, when pancreatitis occurs in the setting of pancreas divisum, typically involves the body and the tail and spares the head, and I'll show you why. ERCP is always diagnostic, but if you think about it, you can also identify divisum on multi-detector CT and also MRCP. So this is the classic appearance on ERCP, where the gastroenterologist advances the scope to the major papilla, injects, and you see this shortened duct. This is actually the duct of Wirsung. He has not filled the duct of Santorini. All right, so this is the ventral duct, which is clearly truncated. However, when you look at the termination of this shortened duct, you'll see that there's normal branching pattern. In contrast, when you compare a case of adenocarcinoma, you can see you have a shortened duct of Wirsung, but there's absolutely no branching at its termination. All right. Now, this is a patient with divisum demonstrated quite nicely on CT. And you have a dominant duct of Santorini. This is usually not the dominant duct. The Wirsung duct is usually dominant. But here you have a larger duct of Santorini. And the reason why with acute pancreatitis in the setting of divisum, why you have diffuse involvement, is because now the Santorini duct is draining by far the majority of the gland through a minor papilla. Okay. And here's the truncated duct of Wirsung, again, draining through the major papilla. So this was written up, and this is actually termed the dominant dorsal duct sign. And here's, again, just a nice demonstration in two different patients of that same finding who had pancreas divisum. The second congenital anomaly is annular pancreas, and this is where you have a persistent band of pancreatic tissue that encircles the second duodenum. Now, half of patients will present in the neonatal period with the classic double bubble sign and obstruction, but a half will present as adults and typically either with pancreatitis or ulceration in the periampullary area. And again, multi-detector CT or MRCP can often diagnose annular pancreas, and you don't need ERCP. You should be familiar with the appearance on ERCP, though, because it's pretty classic. And this is, again, where the scope is sitting in the second duodenum. You can see the injection of the Wirsung duct actually comes and circles the scope, which is in the second duodenum, and then crosses midline. All right? On upper GI, what you would see is just a short segment circular stenosis. And here's a patient. You can see you can actually follow the duodenum straight into the pancreatic head, which is enlarged. All right. Use your multiplanar reformats to really trace out the duodenum that enters and traverses through that pancreatic head. All right. A pretty easy diagnosis here. What about this case? You see this and you're thinking, wow, is this an adenocarcinoma, hypovascular mass-like appearance in the pancreatic head? However, there's no pancreatic ductal dilatation, there's no biliary ductal dilatation, so no double duct sign. You give some contrast and you can see that this is just the second duodenum, okay, a case of annular pancreas. All right, let's move on to our solid masses of the pancreas. And adenocarcinoma is the most common, represents 90% of pancreatic neoplasms. You can see that it is still one of the leading causes of cancer deaths in this country, with about 40,000 per year. Commonly occurs in older men, and prognosis still remains dismal, with a 5-year survival of less than 5%. This just demonstrates that the majority of cases still sit in the pancreatic head, and this is the area you should focus on, about 70%. You are all familiar with the signature appearance of pancreatic adenocarcinoma, a hypodense mass, typically, as I mentioned, in the pancreatic head, the double duct sign, where you have dilated pancreatic duct beyond the level of the mass, and dilatation of the bile duct above the level of the mass. You may also see atrophy of the gland beyond the level of the mass. On ERCP, very nicely, you can see the double duct sign where the mass is sitting right here, and dilatation of both the pancreatic duct and the bile duct beyond the level of the mass. Correlated very nicely with this coronal planar reformation, the mass, you can see hypodense mass sitting right here, and the two dilated ducts. Classic appearance, hypodense mass with glandular atrophy and dilatation of the duct beyond. Now, what about this case? I challenge you to find the mass itself. We've got clearly double duct sign, right? So we know there's something going on. There's got to be a mass there. But you can see that in up to 10% of cases, you actually will not be able to identify the primary lesion because it's isodense. And the good news, though, is that with these isodense masses, they have been found to actually have a better prognosis. T&M staging of pancreatic adenocarcinoma. T1 and T2 is where the tumor is still confined to the gland, and it's just a matter of the size of the lesion, less or greater than 2 cm. With T3, you have local direct extension to adjacent tissues. T4, more advanced direct extension and involvement of the larger arteries, celiac and SMA, making it unresectable. So what are the criteria for unresectability? This is what the surgeon wants to know. And if you have encasement of the main arteries, as I mentioned, and by encasement, I mean greater than 180-degree involvement of the circumference of the artery. If it's less than 180 degrees, the terminology that is preferred is abutment. If you have encasement of the aorta, the IVC, occlusion of the SMV or portal vein, and then obviously with distant metastatic disease. So here we have a case clearly unresectable where we have encasement of the celiac and branch vessels. Here's a case where we have an unresectable lesion with encasement of the SMA. With the coronal reformat, we nicely delineate the extent of involvement. Now, there's a sign that you should know about called the teardrop sign, and this is where you have tethering of either the SMA or the SMV by the mass, and this is considered to be another sign of unresectability. Now, this tethering can be posteriorly, but can also be laterally. So here's a nice demonstration of really teardrop sign involving the SMV, but tethering it, you can see laterally. This is the laundry list you should know about for the differential diagnosis for adenocarcinoma of the pancreas or hypovascular mass. We've already gone through the pancreatitis, necrosis, focal fat is in there in the benign category, and then these are the lesions in the malignant category. Okay, let's move on to neuroendocrine tumors, the PNET tumors, I call them, in the past termed islet cell tumors. And there's been a change that you should know about in that in the past, functional neuroendocrine tumors were most common, and in particular, insulinoma and gastronoma. However, over the past several years, there's been a lot of literature that has come out documenting that, in fact, the non-functional types of the pancreatic neuroendocrine tumors are by far much more common than the functional types. All right, so up to 75% of cases of the PNET tumors are actually non-functional. This is not good news. Why? Because most of these are malignant, right? Up to 90% are actually malignant. Up to 50% will have metastatic disease at the time of diagnosis. These tend to be fairly large, mean size of over 5 cm. About a fourth will have calcifications. And we'll talk a little bit more about the functional types. Now, the characteristic appearance of these neuroendocrine tumors is that they demonstrate intense enhancement on arterial phase imaging for both CT and MR. The only caveat to that is with the very large non-functional tumors, when there's evidence of necrosis, they may not demonstrate this intense arterial phase enhancement. So here's a patient who has, you can see a calcification in this mass that is hypervascular. So what's your top of your diagnosis list? Non-functioning, right? What about this case? We know it's malignant, right? We've got liver mets already. It's got a dot of calcium here, very large, certainly over 5 centimeters. And again, this is non-functioning pancreatic neuroendocrine tumor. Now, let's look at the functional types. And, I would say if you had to have a neuroendocrine tumor, insulinoma is probably the one that you would like. It is the second most common of the pancreatic neuroendocrine tumors. You can see that over 90% are benign, right? This is in contrast to the non-functional type and resectable. They tend to be small, on the order of about a centimeter or less. And there is an association, a mild association with MEN1. Gastronoma is the third most common neuroendocrine tumor. 60% are malignant and 60% are multiple. You're all familiar with it as the etiology of Zollinger-Ellison syndrome. And there's a higher association with MEN1, 25% compared to only 5% for insulinoma. So here's a clear insulinoma. You can see focal intense enhancement on arterial phase, very small. There's an insulinoma in this patient also. This is more of a venous phase image. Can you find it? And this is really just to emphasize the importance of, if you think the patient has an insulinoma, you must perform the arterial phase imaging. Why? Because look at this. You would have completely missed this lesion if you didn't perform the arterial phase. What about this case? Where we have homogeneously enhancing pancreatic mass, and this was a gastronoma, right? This is too large to be an insulinoma. Here are 2 different patients. You see the massive rugal fold thickening. Here's the mass coming off of the pancreas in this patient. Hard to see, but a little bit of a heterogeneous mass coming off of the pancreas here. But look at these huge rugal folds. And what is this? Gastronoma, right? Causing Zollinger-Ellison syndrome. Now, just as a reminder, gastrinomas do not have to be located in the pancreas proper, all right? And in fact, 90% of gastrinomas are located within this gastronoma triangle. And so the triangle is formed by the pancreatic head medially, the junction of the cystic duct and the bile duct superiorly, and then the junction of the second and third duodenum inferiorly. And so when you look at this image, where is the gastronoma? You're still looking for something that's hyper-enhancing, that's intensely enhancing. And here it is. Okay? What about this? This is a very leading question here. What is the diagnosis? Right? So this is another gastronoma. The differential diagnosis for a hypervascular pancreatic mass, METs certainly can be hypervascular, and at the top of the list is renal cell carcinoma. Less commonly, we'll see sarcoma, melanoma, carcinoid, and thyroid. And then you can have accessory splenic tissue that implants into the spleen, into the pancreas, and typically this is in the tail, and it enhances just as the spleen would, and is seen as hypervascular. So here's a patient who has had a nephrectomy. You can see the clip sitting right here, and several foci of hyperenhancement, and these were metastatic lesions due to renal cell carcinoma. This is demonstration of a hypervascular lesion sitting in the pancreatic tail. Notice that it is isodense to the spleen, so it really just sort of, the appearance really parallels the spleen on each phase. You can use radio-labeled RBC scan to evaluate for splenic tissue. And here you can see uptake clearly showing that this is just accessory spleen that has implanted into the pancreatic tail. All right, let's move on to cystic pancreatic tumors. And these are less common, representing up to 10% of all pancreatic malignancies. And my focus really will be what I have highlighted in yellow. And serous cystadenoma is the first lesion we'll go over. This is a benign tumor. There is a female predominance at an older age. So this has been called the grandmother lesion. There is no predominance for any portion of the pancreas. However, about a third will have a central scar and calcification. The classic teaching is that you have many small cysts, so numbering greater than 6, and each of the cysts should measure less than 2 centimeters. And the cysts contain glycogen. Of note, there is an association with von Hippel-Lindauer disease. This is a cut section showing you this very nicely, this fibrotic central scar. You can see the innumerable small cysts scattered throughout the tumor. Just to show you 2 different types of serous cystadenoma, you can see the central calcification in both. Here the cysts are a bit larger, but certainly measuring right about at the 2 centimeter mark, and you have smaller cysts in this particular patient. Mucinous cystic neoplasm. This is the macrocystic tumor. These are frankly or potentially malignant. There is a higher female predominance compared to serous cystadenoma, but occurring at a younger age, mean age of 50. So this has been termed the mother lesion. There is a preference for the tail of the gland, and calcifications when they occur are less common, and they tend to be in the rim of the lesion. I'll also mention that calcifications, when you do see them in the setting of this tumor, has been found to be a predictor of frank malignancy. And again, the classic teaching is that you have fewer cysts, but they're larger, so numbering less than 6, and each of the cysts should be greater than 2 centimeters. On cut section, you see these larger cysts. You can see mural nodularity, and here's a large nodule, here's another one. And as I mentioned, 15% will have this rim calcification. When you see calcification, this is much more likely to be a malignant, already frankly malignant, and obviously comes out. Here's another lesion, unilocular in appearance, thicker wall, and you can see wall calcification posteriorly. All right, moving on to the solid and papillary epithelial neoplasm, also termed the Sapin tumor. In the literature, you'll see this referred to as the Franz and the Hamoudi tumor as well. These are uncommon but low-grade malignancies. They tend to occur in younger women with a mean age of 25, so this has been referred to as the daughter lesion. They tend to be fairly large and pliable tumors. They do have a capsule. Often you'll see some solid component to these tumor, and the cystic portion occurs when there is necrosis in the larger lesions. Now, hemorrhage is a common finding found in almost all lesions, and necrosis as well. And the good news is that when you resect these lesions, you're considered to be cured. So here are 2 different patients. You can see here is one that looks completely solid. Here's one where we can see that there's some central necrosis and cystic appearance. This is from the AFIP, but also updated, and you can see mean size was 9 centimeters. Earlier studies showed that there really was a preference for the tail, but more recent studies, as we've accumulated more cases in the literature, have found that there's actually no preference for any part of the pancreas. Hemorrhage, I mentioned, was very common finding, 100% in this particular study. Calcifications, close to a third, and then interestingly, in about 20%, you can see a fluid debris level. So this is on T2 weighted MR, demonstrating nicely that there is a capsule and the solid and cystic nature of this tumor. You can see that there are different areas of hemorrhage in different stages, and interestingly here you can see, as I mentioned, about 20% of cases, you can see this classic fluid debris level. Okay. All right, moving on to the IPMT, the intraductal papillary mucinous tumor. It's also called the mucinous ductal ectasia. And the mucinous ductal ectasia terminology actually describes quite nicely what you see on imaging. So there's a range of histology from benign epithelial hyperplasia to frank carcinoma. It tends to occur in older women, but with a very small female predominance. There are three main types that you should know about. The first type is when the main pancreatic duct is involved, and this can be diffusely, and then the differential would be chronic pancreatitis, or you can have just focal involvement of the main pancreatic duct. The second type is the branch duct type, and there are various subtypes in that you can have clusters of smaller cystic appearing lesions or clusters of larger cystic appearing lesions. And so the micro or macrocystic dilatation, these can simulate the cystic tumors that I just talked about, the serous adenoma and the mucinous cystic neoplasm. And then you have a combined ductal type where you have involvement of both the main duct but also of the branch ducts. I can tell you that the main duct type has worse prognosis. The branch duct type obviously has better prognosis. The combined duct type carries the same prognosis as the main duct type, so a worse prognosis. Now, ERCP is often diagnostic in that the gastroenterologist will see a wide open patulous papilla with mucin pouring out of it. If they are able to advance the scope and look into the duct itself, they may actually see mural nodules. As I mentioned, the differential diagnosis is chronic pancreatitis, particularly when you have involvement of the main duct, and the cystic tumors when you have involvement of the branch ducts. This graphic should bring that home for you. This is a patient with what? Just segmental involvement of the main duct, right? So worse prognosis. This patient has the combined ductal type, involvement of the entire main duct, but also these clusters of cysts, so involvement of the branch ducts as well, right? Worse prognosis because the main duct is involved. This simulates the mucinous cystic neoplasm. This simulates the serous adenoma. What about this case? You look at this, it's very nondescript on non-con CT. However, on the T2 weighted MR, beautifully demonstrates, doesn't it, the pancreatic duct and then actual connection with this cystic mass. And this was the branch duct type of IPMT. When you see this association of the duct to the lesion, it's diagnostic of IPMT. The only other thing in the differential would be potentially a pseudocyst, remembering that a pseudocyst forms from rupture of a pancreatic duct. As a reminder, the branch duct type is less likely malignant, and in particular, size here does count, so if it's less than 3 centimeters. And these are lesions that you can actually follow up, preferably with MR. And here it is on the MRCP. You can see very nicely, again demonstrated, the connection to the pancreatic duct. And this case, again, very ill-defined on the CT. You can see on T2 weighted MR, a cluster of small cysts. This is the branch duct type of IPMT simulating what? Serous adenoma. This easily could be a serous adenoma. However, when you see connection to the duct, all right, that nails the diagnosis for you, that's much more likely to be the branch duct type of IPMT. Here we have an atrophic gland, but there's no calcifications. You have diffuse dilatation, irregular dilatation of the main pancreatic duct. And this was the diffuse main duct type of IPMT. These are more likely malignant. These patients have to go on to surgery. And this is from that same patient. You can see the markedly dilated main pancreatic duct with multiple filling defects. These defects can due to just globs of mucin or to actual mural nodules. And this is what the gastroenterologist sees, is just this sort of gaping papilla with mucin pouring out of it. Here's another patient with a diffuse main duct type where you have enlargement of the entire duct. You see some wall nodularity and irregularity throughout the entire duct. On PET, you can see that correlated to the areas of thickening and irregularity, there's actually increased uptake, right? And this was clearly malignant. Here's a case of combined ductal type where the main duct is certainly dilated, but then you have a cluster of cysts also in association. So involvement of both the main and the branch duct carries a worse prognosis. And this was a paper published by Dushyant Sahani documenting the predictors of malignancy for this particular tumor. And there were 4 of them. If you find mural nodules, intraductal calcifications, interestingly, would be a predictor of malignancy, thick septations, and then if you have a markedly dilated main pancreatic duct greater than 10 millimeters. So the key points for this lecture to take home are that you should be familiar with the subtypes of chronic pancreatitis, groove and autoimmune pancreatitis, and that they can appear as hypodense masses, particularly in the pancreatic head, simulating adenocarcinoma. Note that up to 10% of adenocarcinomas are isodense. So if you see all of the findings, except you can't find the primary, it's still there, okay? Don't write it off. And then pancreatic neuroendocrine tumors have a classic intense enhancement appearance on the arterial phase. And of note, the non-functional type has overtaken the functional type and is now known to be the most common PNET tumor. Okay, I think we'll move into our SAM questions, if I can have those, please. I have 5 questions for you. They are all image-based. Case number 1. 52-year-old male with history of alcohol use presents with abdominal pain. And based on the image, what is your diagnosis? And the answer is groove pancreatitis. And again, we see this sort of ill-defined soft tissue sitting in that characteristic pancreaticoduodenal groove. You even see some calcifications here, evidence of chronic pancreatitis. Okay? Case number 2, this is an incidental finding. I know you got this correct. This was annular pancreas. And here you can follow actually the duodenum straight into the center of this enlarged pancreatic head. Okay. And case number 3, palpable mass in a woman. What's the most likely age range? And the answer is 25 to 35 years old. So this has the characteristic appearance of the Sapin tumor, right? The solemn papillary epithelial neoplasm. It's known as the daughter lesion, okay? Next case is a 62-year-old male with abdominal pain. And what is the most likely diagnosis? All right, this tests your short-term memory. So this is going to be branch duct IPMT, right? And again, you can see very nicely the connection to the duct right here. And finally, case 5, this is a 50-year-old woman with sweating and palpitations. And what is the most likely diagnosis? And this is an insulinoma. And again, by far, about 90% are benign. They tend to be very small, intensely enhancing on arterial phase. You can see this one is just about 1 centimeter. So with that, thank you for your attention. And I think that you now have a break.